The goal of the Aligner Intensive Fellowship is to equip an orthodontist with all of the tools and knowledge needed to treat every case type with a clear aligner and to have confidence behind doing so. You also need to know your lanes, right? Because you're not going to treat every single case with an aligner as well. So it really helps to hopefully keep people in that confidence zone to be able to treat cases successfully and to choose the right case type for an aligner as well.
Hello there, everybody, and welcome to another episode of the Orthopreneurs podcast. Today, we have somebody really special. I say that every time, but I mean it today. Please welcome Dr. Maz Moshiri. Welcome, Maz.
Hey, Glenn. How are you?
I'm good. Thank you for being here.
Thank you for having me.
You're like one of the busiest people in orthodontics, and so the fact that you're here and other stuff you have going on, we'll talk about later. But just thank you. I can't even imagine how crazy your schedule is.
I appreciate the invitation. I'm honored to be here.
Yeah. And, for those of you listening, you probably, unless you've been living under a rock, you probably know who Dr. Moshiri is. He's lectured literally, I think, everywhere on the planet for a long time about a lot of things. But we're going to take the conversation in some different directions today, because most are probably expecting us to sit and just talk about attachment designs or, sash attachments, which, by the way, changed my life. I just want to say that sash attachments. I am Mr. America. I wear so many sashes in my patients' mouths.
They work.
That was sash attachments, right?
No, I unfortunately have to give that credit to Jonathan. Unfortunately.
Oh, are you yin yang, or is that Jonathan too?
That's also Jonathan. That's
also Jonathan.
Maz. Yeah, I know.
I
contributed nothing.
We can't give him credit for anything. We're going to just erase the first 2 minutes of this presentation because we can't let him hear this, okay? Those Gucci loafers will be floating off the ground. Anyway, for everybody who knows, Maz Moshiri is partner in crime. I have Doug Shaw as my partner in crime. His partner in crime is Dr. Jonathan Nicozisis. Together, they run the Aligner Intensive Fellowship, which I've been through, and we'll talk about it a little bit later on. But let's start here. Let's start with your journey, because your journey is really interesting. And if you don't mind bringing people up to speed, as much or as little as you want to talk about, how did Maz Moshiri end up where he is today?
I'm from St. Louis, Missouri, born and raised. And my mom and dad are both specialists. My father is an orthodontist. My mom is an endodontist. They moved here from Iran, late 70s, to go to specialty school. Dad actually started out as an endodontist and hated it and quit after 2 months, and wrote a letter to the Shah of Iran at the time asking for him to allow him to switch specialties and to stay in the United States, which he was granted that privilege.
So just in the late 70s. Yeah. So this was before the revolution, which was what, 79?
Exactly. Yeah.
So they came over, like we see a lot of people in my residency. There were a lot of Saudis who were being funded by the government to come and get trained in pros or peri or ortho. So so the plan was for them to go back to Iran afterwards. 100%. But I'm willing to bet there were some small changes in the geopolitical environment in Iran that caused them to probably stay in the U.S., right?
100%. Yeah. Revolution broke out, and their parents said, it's not a good idea to come back, and you guys have to figure it out. And so they, stayed here and had to go through dental school again to get their U.S. licensures. And while my dad was in dental school, he was asked to become the chairman of the ortho program at WashU. So he was in dental school trying to become a dentist in the U.S., and yet he was chairman of the program at the age of 28.
Oh my gosh.
And so I don't think I was still tying my shoes at the age of 28. So I don't understand how he was doing that, honestly.
That's incredible.
Mom also taught at WashU until they figured out what they were going to do. They ended up staying in St. Louis and setting up private practice. Being a first generation immigrant here, everything and the whole focus eventually becomes on their family, obviously, because they didn't have much family here. So when we were born, I think my dad, all he ever wanted was for us to, have a good life and to, he equated that with being a physician or a doctor, so there was a heavy influence on me to go into that route. I got into med school out of high school. I didn't go.
Hold on, time out. You just glossed over that. You got into med school out of high school?
Out of high school. I got into a 6-year accelerated med school program at University of Missouri, Kansas City. I broke my father's heart when I told him I didn't want to go, because there was a piece of me that was convinced that I needed to go to college to have that 4-year experience to just figure things out in terms of just being a better human more than anything else, and not be so focused, because I felt like I was so focused through high school that I just needed a break mentally. So I went to Emory for undergrad, and then decided that I did want to switch career paths, if you will, and go into dentistry. And went into University of Louisville, which is where my father actually taught. He was teaching there at the time. So after he was the chairman at WashU, and he stepped down from that role, he was invited to teach at the University of Louisville, and he would fly in on a Sunday, teach Monday, Tuesday, fly back Tuesday night. And he did that once a month for 28 years straight.
Oh my gosh.
Never missed a week.
Wow.
And so it was a blessing, because when I went to school there for 6 years, he would come in town once a month. We'd go grab a nice dinner. We had a condo in downtown Louisville. So that was a blessing. And then my sister joined. So my dad got to see us for basically 10 years of his teaching. He was with his children.
That's
which
great.
was incredible. Yeah. So it worked out extremely well. And then I came back to St. Louis, and here we are on this podcast. So
that's awesome. So when did you start your practice? Well, you didn't start it, right? You joined your dad.
I joined him in 2017, 2007. 2007.
I was gonna say, man,
yeah,
I got more experience than Maz.
But it's crazy to think that, I mean, that's just, I can't believe how much time has gone by. I know there's people in much more practice much longer than I've been, but just looking back on it, it really does fly by. It's kind of weird to say that. I don't think about that too much as to when I actually started practice, to be honest.
No, they always say the days are long, but the years are short. And
that's right,
it's amazing how quickly it goes by. So, there's so many things we could talk about, and we'll get to the Aligner Intensive Fellowship and technology. And, we chatted before we came on the air. Here's a spoiler alert, folks, or a little behind the scenes. Before we actually start recording, I generally will sit and talk to the guests a little bit. And one of the things that we talked about was the fact that about 4 to 5 months ago, I moved an existing practice location into a new location, built a new office, and Maz is in the process of doing that as well. And so we're going to talk a little bit about sharing our experiences of what we think we can bring to the table to help all of you who might be considering moving somewhere. But one thing I want to start with, let's right out of the gate, I want to make enemies right out of the gate. I'm coming out swinging, Maz.
Feisty.
Yeah, I'm feeling feisty today. They should put on that, shipping off the Boston song, right? Like they have in the Samuel Adams commercials or something. I was really fortunate and honored to be able to come visit your practice. You're so giving in that way. And even got to stay in your house, which was awesome. The bouncy castle was my favorite. But you're a gracious host, and you were so giving of your time that day and allowed me to really get to see a ton of different cases, types. And what was really interesting to me, by the way, everybody out there, you should know this, that when I first became an orthodontist, for the first, 3 to 5 years, I would ask everybody, can I come visit your office for the day? And if you're not getting on the road and visiting offices, I mean, that's a conversation in itself, right? If you,
Invaluable.
The people out there who just allowed me to come into their practices and observe them from the day. I think in 1 year, I went to go see Chris Feldman, Stu Frost, Jim Stork out of Iowa is amazing. I got some great information from him. I just had a book. I'd bring my iPhone and a book, and I'd take notes all day long, and I'd take photos and put them into an album just all day long. And I'm telling you, folks, at the very least, if you're not going to visit people's offices, it's huge. Did you visit a lot of offices early on?
Before I joined my father's practice, I visited about 6 offices. I took off a couple months, and I made it a point to go to 6 different offices because I wanted to, honestly, just cherry pick ideas to come in and have something to bring to the practice. And I, just like you, had a notebook, and I got a bunch of ideas. I learned a lot of clinical tips and techniques, because you visit these doctors that have been practicing for 20, 30, sometimes 40 years. It's just, you can't put a price on the amount of information they have in their heads and what they've gone through and the mistakes they've made. But they can glean off to you in a heartbeat, just like this. You're just picking up pearls left and right. It's incredible.
You're one of those guys now, Maz.
You're one of those guys. I don't know about that. I'm working on it still.
Yeah, well, you're humble. You're humble as you are. You're as humble as you are knowledgeable. And like for instance, you guys say, "Well, I know enough clinical." Walking into Dave Paquette's office, that was another one I visited. His hub and spoke model of his office, the design was brilliant. all the financials and everything were in the middle of the office, and everything came off like a wheel front. It was just like you learn so much by going to people's offices. So if you get nothing else out of this podcast episode today, please reach out to somebody and go visit their office. And yes, you can come visit mine. And I'm not going to speak for Maz. He's giving you the hand sign. Come visit him. You're about to get 350. And I will say there are people out there, and folks, don't take it personally if you run into them. I'm not one, and I don't think Maz is, that are going to charge you to come for the day. There are people out there, and I'm not going to mention names because it's their privilege and their right to do that. But if someone's asking, you get 200 requests a year, I want to come visit your office, and it starts interfering with the day-to-day flow, they just want you to have some skin in the game, right? To say, look, it's easy for you just to show up and disrupt our day, but just to let you know, Dr. X charges this amount for you to come visit. I don't do it. I know you don't do it, but if you ever hear anybody say that, you don't get too upset at them, folks, until you're in their shoes. So I came and visited your office, and one of the things I saw, well, there were two things I saw, and I'd like to talk about both of them. The first thing I saw is you're very comfortable doing splint therapy on patients, right? It's something you and I have in common. Talk a little bit about, first of all, where you got comfortable with occlusion and splints.
To be honest with you, it's my dad. My father really took a very special interest in temporomandibular dysfunction. He started a study club in St. Louis called the Craniomandibular Society that he ran. He brought in Ron Roth, Mariano Roccabato, who's a physical therapist out of South America, Dawson, Pankey. He brought in all these speakers over time, and really just took a very, very special interest in treating TMD. And it's to the extent now where in St. Louis, we're one of the only people that touch it. There's a significant need for it, meaning that patients are suffering from it and they really don't have a place to go to be helped outside of maybe going to a neurologist at times, or when they're seeking things, chiropractor, maybe a dentist here and there, but to actually, or oral surgeons obviously at times, but to find orthodontists are comfortable with it, or even dentists for that matter, still is few and far between. And from what I'm experiencing, at least in St. Louis.
Yeah. And again, you and I talked a little bit about it. I interviewed Tom Pitts recently, and he went through the Roth course as well. And in that interview, I asked the question, right? And I asked you about it beforehand. And by no means do I want to get you in trouble. I don't mind taking the beating on my back. I did 3 years of just nothing but what you just talked about with your dad: occlusion, Pankey, Dawson. But I did 3 years of it at University of Washington in a very special course with just 8 other doctors from around the country, and 3 years of mounting cases and learning about pantographic tracings and hinge axis locations. And it was a nightmare for everybody listening. Right now, people are going to need therapy because they're just hearing words like hinge axis location, right? And centric relation. But as a restorative dentist at the time, how can you do a full mouth reconstruction and not know how to find CR and build from there, right? We learned that's a repeatable position. It also happens to be a place where muscle function drops. Right. It happens to be a place of comfort for most patients, centering the head of the condyle and the fossa. But I asked Tom Pitts, I said, if this is so important, because to a person, every orthodontist I know has been practicing over 20, 25 years, the best orthodontist I've ever met clinically, the best, to a person, have all been through the Roth course, every one of them, your dad obviously included. There's such another level once they understand occlusion. And yet, in ortho residency, I mean, I've visited Detroit when I was interviewing and looking, and Dr. Kulbersh there was really, the day I visited, they were doing full hinge axis location and clutches and the whole 9 yards. And I think the students wanted to pull their hair out. I was in heaven, right? But other than that, I don't know if there's a lot of programs that actually teach occlusion and teach TMD. And I'll say it over and over and over again, folks. You've heard me say it on other podcasts. It will save your bacon. When you've got that case that's finished and the person goes, oh, my bite just doesn't feel right. I mean, I like my smile, doc. And there's a CR, maximum intercuspation shift, that you're not spotting, and the muscles are firing, and the pterygoid is angry, and temporalis is causing headaches. And you're about to send them to a neurologist or oral medicine person, and you could probably solve it in like 7 minutes in your practice. Why do you suppose we're not getting that in most ortho residencies? And again, if you don't want to weigh
no,
in
I
on
mean,
that one,
I feel like it's becoming a lost art, kind of like tweed. I mean, in terms of like, you're not seeing a lot of wire bending being taught in residencies anymore either. And I think some of the giants that were taking that on are retiring, or unfortunately may have even passed away. I think Roth maybe has morphed into Face, which is I
out of
think
San
Doug Knight has
Francisco,
been a big part of that in San Francisco as well. Yeah, I think, but that study group, lives on, but you have to go outside of your education to learn it. To your point, it's something that you have to do almost outside of residency. Um, I don't know why it's not being taught in schools. To be honest with you, Glenn, I feel like it's becoming almost a lost knowledge that you have to seek out on your own, unfortunately,
yeah,
because I have a lot of people that when I lecture, I talk about and I show TMD cases that I then subsequently will detail with Invisalign post splint therapy. And then I have a bunch of people asking, well, where can I go to learn this? And I said, I wish I could lead you to the direction. My father taught me everything I know in terms of how to manage TMD.
at some point I might, there's great people out there like Ron Ronconi, right? He does a lot of
Yeah,
it.
absolutely.
And I may at some point put on a course of basic occlusal principles. Like, the course I took at University of Washington, again, it's a lost art, right? I took it at the turn of the millennium. So that should tell you 25 years ago, give or take, it was a 3-year course. And my oldest wasn't born yet, and she's living in Manhattan, working a job, and she's 24. And the interesting thing about it is that at the end of the day, I'd say most orthodontists can't even differentiate between TMD and myofascial pain,
Mm-hmm.
right? Person comes in, they got pain. I'm sending it out to a specialist, and they're scared of it. And I'm saying,
Right.
we can solve this, and so we're going to figure out a way. But so you do a fair number of splints. Do you do you charge for the splint itself, or do you include that as part of the orthotherapy at an increased price?
So we charge for the exam, which we normally don't charge for consultations. But for a TMD exam, we do charge because it's a longer exam. Obviously, it's
I
much
know,
more
and I don't
involved.
do that, and I should. I
Yeah, we
should.
charge 380 for the TMD exam because it's about an hour of time that the patient's in the practice, and of that, it's about half an hour doctor time, honestly.
Yeah,
So it does throw
understandable.
us off on our schedule, but it's an involved exam. And then the splint therapy we charge as a phase one. And the reason why we do that, philosophically speaking, is that if I haven't helped the patient with splint therapy, I don't want to put them in orthodontics. And so we try to do that as kind of a diagnostic phase as much as it is a therapeutic phase to some
Got it.
extent. And then because
As it
honestly,
should
some
be.
people,
It
as
should
it
be a
should be,
diagnostic phase, because what
yeah,
happens if you put them in CR, they've been in an adaptive position, they were class 2-ish end on
yeah,
when you saw them, and now in centric, they're a full cusp class 2. Your entire
absolutely.
treatment plan has changed.
100%. Yeah. And some people we don't help. Some people I do everything I can to help them with their pain and I can't help them. And so then I don't want to confine them to being forced into orthodontics. So we then make alternate referrals on an as needed basis. But does that happen very often? The answer is honestly no. Majority of people we are able to help. But because of that reason, and we tell people that, we always tell people in the beginning, your prognosis is unknown, meaning that we hope to help you, or I think it's a favorable outcome. But at the bottom of their treatment letter, it always says your prognosis is unknown. And I think that's what people get scared of is that, well, what if I can't help this person? Because you always think about that one, right? And
Right.
then we get stuck on that one,
Always worst case scenario is the only thing you think about.
right? But that's not, you're going to help so many people, especially as orthodontists. We understand occlusion so well that we can also manage the changes. So as you mentioned, someone does drop back from a Sunday bite, or I think you and I will eventually get into restricted arc of closure. Potentially, a lot of people need
What
to have
makes you
more
say
overjet.
that? Why would we get into
It's a hunch. uh, but
Spoiler
some
alert, restricted arc
spoil.
of closure is coming, people.
But those patients need help to have more overjet. They need to come more anterior with their mandible. So
Yeah,
how do we do that? We do that. That's our job, right? That's what
right.
we do.
Well, you said we know occlusion, but the truth of the matter is the overwhelming majority of orthodontists don't know occlusion, right?
To that extent, yeah.
I'll throw something really interesting to you, and ask Dad if he ever heard this one, because there's the big knock, right? I heard somebody who went to a school not far from where you practice. you know, I heard that there once was a guy who ran the program who could have been a little controversial and outspoken, published a lot, gave a lot to the profession. Um, but someone once invoked his name and said, you know, he said that, you know, an articulator, you know, gnethology is a study of articulators, right? Like, which is just, you know, in a menial way, it was said. And again, it's kind
Sure.
of a silly comment. But there is a lot you can poke at when it comes to gnethology, which was originally invented for dentures to understand the jaw movements, the stomatognathic system, or what have you. And there's a lot you can poke fun at because it's hard to run literature. There is a lot of
Hmm.
literature. There's bodies and bodies of literature, but it's hard to run really good clinical literature on occlusion. It's hard. It's just really difficult to do. So there's a lot of, you know, old school, old spun wisdom, kind of like, you know, your mother didn't go to become a chef. And I'm not saying your mom, but one's grandmother didn't go to become a chef. But if you sat in the kitchen with her for a month or two, you'd learn a lot of really good ways to cook a meal, right? You'd learn a lot of, you know, this is how you do this. This is how you do that. How'd you learn
Yep.
that? Trial and error. Check this one out. Ask your father this. Did he ever hear about an anterior sign on one of the anterior teeth when there's a contralateral balancing interference? And the answer is excessive wear on an upper lateral incisor is usually indicative of a balancing interference on the other side.
Hmm.
Now, there are people out there who are going to go, that's bananas, it's crazy. But think about this. When you go to excursion and you cross over off the cuspid, what's the next tooth that generally hits? A lateral. Because once you get past the cuspid, the jaw now unlocks and your anterior teeth are going to rub against the lateral. If there's a balancing interference, what's the pterygoid, masseter, and temporalis on that contralateral side doing? They're pressing hard when you no
Yeah.
longer have cuspid rise. And then you get, and I got to tell you, every time I saw accelerated wear on a lateral, upper lateral, they were in fact right. And I learned
Hmm.
this from Jerry Schultz, may he rest in peace, who taught the 3-year course, who shared a lab bench at USC right next to PK Thomas. And so I had the opportunity to learn it. But my point here is there's so much about gnethology that can teach us about how to treat people better that it shouldn't be a forgotten art. And as far as
I
the
agree.
tweed and wire bending goes, the only reason that's disappearing is there is these two jackwads who are teaching people how to do plastic really well. And and they're learning how to
Oh
do
man.
plastic so well. So I don't know why wire bending is going away, Maz. It's such a surprise to me.
I gotta tell you though, the interesting thing is I went to the 2-week tweed course and it taught me so much about anchorage and anchorage control and setting up and controlling the vertical dimension. So many of those principles are what shaped how we do plastic. And it's
Okay.
because it's just orthodontics at the end of the day. And I appreciate the compliment, but it's just, you know, I don't know if having that knowledge, if I didn't have that knowledge, if I would be where I was at today with my acumen with aligners is
I
the
agree
point.
100%.
And so I hope
100%.
that it's not lost upon people, meaning that
Mm.
future generations, I really hope that somehow they can get that. Because I know we're not going to be setting up, you know, bending in tip back bends, probably in our wires anymore, things of that nature that were taught, J hook headgear, all these things
Speak for
are,
yourself, Maz, okay? Just speak for
you
yourself.
know, for the most part going away. But I don't know. It's, the futures, you and I discussed this previously in terms of, I think, our affinity for what the shaping of the future is going to be. I think it's just stimulating. But you know, those mechanics, where are they going to be? I don't know. You know, 10 years from now, who's teaching them?
There was a moment I had once watching after I went through a liner intensive fellowship, which we'll talk about in a moment, taught me so much. The sort of that moment, that like epiphany about plastic, that like there's before this moment and how I practice, and then there was after this moment and how I practiced, was you always talked about use the same concepts that you use for wires and brackets, just do it in plastic and understand what you're
Yeah.
doing and just apply it with plastic. And I didn't quite get it until I saw you guys with an open anterior bite case where you started to do sequential posterior intrusion of the upper and the lower using elastics to help reshape the occlusal plane
Mm-hmm.
and without extruding the upper anterior teeth, right? Because the edges were in a good spot. You just you closed down the bite, and it was stable and it was beautiful. And I remember seeing that case shared, and I think it might have been Jonathan, the son of a who was showing it, and I said, "This is Miaw. You just showed a
Yeah.
Meow case, because I was lucky enough to have Jorge Coro in my program who taught us Meow. Every Friday we treated Meow cases, the
Wow.
multi-wire edgewise loop
Multi-loop
appliances.
edgewise arch wire. Yep.
Yeah, thank you. We had to bend our own, and so we would
Oh
do
my gosh.
those, but the same exact principle. And it was at that moment it all clicked for me. It was like, holy cow! They're doing the exact same thing in plastic that we're doing in wires, in the same sequence, in the same anchorage control, in the same elastics. And at that point, everything changed for me, thanks to you guys. And so
Well,
I appreciate it.
thanks for actually having an open mind and learning.
Well, open mind, I'm not so sure about. Learning, that's questionable. But restricted arc closure, I don't want to keep you here long. I know we have a
That's great.
timeline today. We're going to spend 60 seconds on this one. When I visited Maz's practice, I noted in Orthopreneurs upon my return, I said, I saw like 4 or 5 splint cases that he was doing, and a couple of them were pivot splints. I think a couple were full coverage, TMD issues. And I said, it's really interesting because every one of them was like a middle-aged female with 4 bicuspid extraction. Now, I didn't say, correlation, causation, the whole 9 yards. I just said, this is what I saw. I saw 4 or 5 women, the only splint patients of the day, N equals 4 or 5, right? I didn't draw any, but I said, it's really interesting. And all of a sudden, everybody came out of the woodwork like, bicuspid extraction doesn't cause TMD, right? Like I clearly had stepped into a world that's been discussed 100 times in ortho well before I got there. And my point was, if you don't understand occlusion, you cannot say that 4 bicuspid extraction in selected cases did not lead to TMD because of what Greg Kinzer was the first guy I ever heard talk about it. He was Frank Spear's associate at the time, 20 years ago, gave a lecture on restricted arc closure, which means the way the jaw closes, like if you ever look at that pantographic tracing, the cell envelope of motion, right? It goes from outside in. And if you retract the upper anterior teeth with some excessive anchorage and you bring them back so they look nice in the face, but they're too far back, your lower incisors will be restricted in how they can close and the jaw has to go distal to close down. And what happens long term? You got your
just slips
disc.
anteriorly.
You have an anterior displaced disc, and you end up with some sort of TMD. And folks, this is not like rocket science. This is like common sense. And yes, 4 bicuspid extraction can lead to that. If you're taking maximum anchorage control and you're pulling them back. So again, that's why we're talking about restricted arc closure, because he and I are geeks and like talking about this stuff.
I think the issue is like we can't say that it's going to cause it, which you and I are not saying.
No.
It's that it's a variable, right? Because it's multifactorial. And can you give someone a worse bite post orthodontics as it relates to their condyle fossil relationship than when they started? The answer is yes.
Absolutely.
If you're not paying attention to those things, and that variable can be one of those variables that pushes the rock over the hill, for that specific patient. It could violate their adaptability over a period of time, that trauma over a period of time on the ligaments of the disc. It can slip. A lot of those patients that we see that have TMD, narrow maxillas. So again, the mandible may be trapped distally, deep overbites, restricted arc closure. I rarely see, honestly, open bite patients that have many internal joint derangement issues. When I see patients coming that are locked or have issues, rarely are they open bite patients. A lot of those patients have more myofascial issues. It's more of the muscular pain.
And why?
So it's just
because they're not deprogrammed.
Right.
And we could talk about that one for days. But the long story, what he's saying, folks, is when you use an NTI appliance, which I don't use other than a day or two, or a Lucia jig, when you use that on the anterior, none of the posterior teeth are touching, what gets loaded 100%? The condyle, because there's no posterior occlusion to support the joint. When you only have back teeth touching, what's going on? The muscles are now playing a much bigger role, and the joint is playing less because the condyle may not be seated fully. So myofascial pain, you'll see a lot more in open anterior bite cases. Joint problems you'll find in posterior open bite case or missing posterior teeth. Did I summarize that well?
You did. You absolutely did. Yeah, the condyle needs support. It needs vertical support, to keep that joint space open. So
I used to listen to a tape series after I took my course from Frank Spear. It was like a 10 disc CD that I used to listen to my car ride every day about occlusion. It's the greatest. If anybody could ever find that and find a CD player for their car, listen to that every day. He will explain so much to you about how all this works. And it's such common sense. We just need to learn it. And so I don't want to.
I ran a Spears group for a while and went to Scottsdale several times and heard him speak. And you're 100. I just want to vouch what you're saying. He's very knowledgeable, and it's very well worth your time to listen to him speak.
Absolutely. But talking and speaking, let's talk about Aligner Intensive Fellowship first, right? I know there's not a lot to talk about. It's a continuum of courses online that you collate material and disseminate it in intervals for people. So there's bite-sized chunks.
Yep.
If you could sum it up in a sentence, what's the goal of the AIF?
The goal of the Aligner Intensive Fellowship is to equip an orthodontist with all of the tools and knowledge needed to treat every case type with a clear aligner and to have confidence behind doing so. And also, in saying that, this is going to be a run-on sentence, to also
say it in
your
German. I love run-on sentences.
Well, I sprechen Sie Deutsch. But, you know, you also need to know your lanes, right? Because you're not going to treat every single case with an aligner as well. So it really helps to hopefully keep people in that confidence zone to be able to treat cases successfully and to, choose the right case type for an aligner as well.
Yeah, it changed the way I practice. I probably should take it again at some point in the near future because I took it when it first came out. I took version 1.0, which was what, 5 years ago, 6 years ago, 7?
7 years ago. And so, we re-recorded all the content. I think it was actually it was this year. This year was released. No, it was, excuse me. It was last summer that the new version was released. And also, as of a year and a half ago, it's officially in all the residencies and of the United States and Canada at no cost to the residents.
Wow.
So the residents can take the fundamentals course at no cost to them. And that's been sponsored by Align to help facilitate that. And so, I think a lot of people will obviously shoot arrows at Align. And I think they've made some missteps over time, understandably. But that's something that they're doing for the profession that I think is wonderful, that they are sponsoring the educational content for every single resident, because they don't have enough. We talked about TWE not being taught. It's because of lack of faculty. If they're not learning aligners, it's because of lack of faculty. Now they have access to the content. So
how does one sign up if they want to take it?
Alignerfellowship.com is where they sign up.
Alignerfellowship.com. That was difficult. With the minute or two we've got left, because I know you're on a time limit today, and I know we talked a lot of occlusion, and
I appreciate you.
Something tells me we'll be doing this again at some point, or I might have you at an Orthopreneurs Summit, or an OPU course or something. In your move of your existing office to the new office, if you could give me, and this is so hard, this is like the old Jewish parable of teach me the Bible while I stand on one foot. If you could give people one piece of advice about your experience, what would that piece of advice be?
Can I give two?
Sure.
The first
one is... Make it a
run-on
sentence and put them together.
I'll make it a run-on sentence. The first one is, I'm in the situation I'm in because I'm not a landlord. Essentially, I'm getting kind of kicked out of my office, for lack of a better term, because we were in a long-standing office that my dad had established in a building that we had moved within the building and built a brand new practice 14 years ago. But that location we've been in for almost 40 years. And a hospital bought the building, and they basically are going to just kick everyone out and, put their own doctors in, understandably. But I wish I would have either signed a longer term lease, had the foresight to do that. So now in our new office, I signed a 10-year plus 2 5-year renewals. Because when you're going to make that type of an investment, I think it's important to have that type of a longevity out of at least the money you put into it. So that's one piece of advice I would give. Obviously, if you could be a landlord, that's probably even better. If you can own the location, because then you're ultimately in control of what your destiny is. We just never were able to do that. The second thing is that through this build-out process, I've always kind of screwed this up one way or the other in terms of if it was my house or the office. And I keep thinking I know the formula. But what I realized is you need to have in my opinion, the GC or in the designer lock and step from the beginning. I've always had one before the other out of order. And it just the costs, they don't see it in alignment. There's change orders or there's value engineering and all this stuff going on. But if they can try to be a team from the beginning, I think that's going to get you the vision of what you want to have, yet stay within the cost of what you need. So the mistake I made in this one is that I have a design team, got the GC later, and the GC's like, you're way out of budget with all this stuff. And now they're like value engineering everything. And It was just out of order. So that's the one big piece of advice I would give.
I was going to say exactly that, because we just moved into our new space 4.5 months ago. We moved our office. I had my architect and my GC. Just because of pure laziness and delegation, I wasn't involved. So from day one, I made sure my architect was there during the bid process to say, wait a minute, are these the faucets you asked for? Are these the lights you asked for? I had to go drive to an office 45 minutes away because the GC had put in a different intensity of light, lumens, versus what she wanted. And, she was saying, no, Glenn, don't settle for it. And he was going, no, it's fine. It's in all our offices. And ultimately, having them there and having her as my advocate changed everything, everything.
Yeah.
So get your architect, your designer on board day one, if you can, during the bid process, so that
Yes.
nothing changes later on. That
Yes.
perfectly said, Maz. I really
Appreciate
appreciate
that.
you being here today, man.
Yes.
We could talk occlusion for days and bore the ever living daylights out of everybody listening, but I didn't want to do that to you any longer than I had to. But
But I think getting a course, Glenn, there's so much demand for it. If you're able to put something together, I think you'd have a lot of interested colleagues that would want to learn that, because it's something that you get from a Spears or a Coyce, or you have to really go out on your own to get it.
and then you're with a bunch of GPs. You're not.
Yes.
If you go to Spirit Coyce, yes, there's orthos there, and I love their Coyce and Spirit mentors of mine in the restorative world.
Yeah.
But that is not, in my opinion, the place the orthodontist should be
Correct.
going. I
Yeah.
think orthos understand ortho, and nobody understands ortho like an ortho. So I could give a course to GPs on occlusion, but it's going to be very different than the course I'm going to give to orthos, because there's so much you don't need to diagnose it too terribly at the beginning if there's no TMD or myofascial, because you're moving everything. You're doing a full mouth reconstruction. You
Right.
just need to know what you're doing while you're doing it. And so
Exactly.
Orthopreneurs University, which has always been online, is about to go live into real live in-person courses this fall,
Nice.
because that's what originally it was planned to be. And then COVID came along and we did everything online. So one of the courses we'll probably have at some point is going to be on occlusion for orthodontists and their teams. So
That's
everybody kind of
perfect.
understands it. So I want to say thank you from the bottom of my heart, Maz, for being here today.
Thank you.
Do me a favor, go find Jonathan and tell him the Eagles suck. Okay, just
I will
say that.
definitely tell
I
him
know he'll
that.
appreciate that. And just wishing you just a great weekend, a great week ahead, and thank you again
Thank
for
you.
everything you do for all of us.
Oh, my pleasure. Thank you, Glenn, as well. Appreciate you, man.